Why do people end up with arrhythmia?
Well, so there are a lot of kind of well-known kind of clinical correlates to arrhythmia. To be honest, when patients come to talk to me about it, before I even dive into medications,
Yeah,
I always talk about, what can they do? What is in their lifestyle, what
yeah.
is in their ability to do to change, the course
Hmm.
of the events. So hydration is very important. If you're underhydrated, a lot of people out there, drinking lots of coffee and not enough water.
Yeah.
That type of lifestyle is not great from the point of view of fainting or syncope, as we call it, or
Mhm.
arrhythmia, PVCs, et cetera, et cetera, et cetera. And, I have a few of my champions, who are coming in as I was fainting or atrial fibrillation. I have, a guy came in and said, I drink 15 espressos a day. And he came in with atrial fibrillation. I said, well, if you're going to be drinking 15 espressos a day, you're going to start fainting as well. I said, well, I've been fainting for a long time, but it doesn't bother me nearly as much as atrial fibrillation.
Yeah.
I had a real estate agent who was sitting next to one of those drip coffee machines. He was drinking 4 liters of coffee a day,
Wow.
right? So it can be done,
Yeah.
but probably not great for you.
Of
Okay. So
course.
we typically recommend as little caffeine as possible. Um, aim on average person needs about 2 liters of non-alcoholic, non-caffeinated beverages a day.
Hmm.
Very simple. If you exercise, you need more. If you don't, maybe you don't need quite as much. If you're a little older and you have heart failure, maybe talk to your doctor.
Hmm.
Alcohol, definite correlation between alcohol and atrial fibrillation. We even have a name for one of the ways it correlates, called the holiday heart syndrome. That's when you have a few drinks over the weekend, you come into the emergency room on Monday morning with atrial fibrillation.
Yeah.
It doesn't mean you're going to ever have it again necessarily. Happens a lot in young people. So we know that having a binge increases your risk of having an episode that doesn't necessarily repeat itself if you don't do it. But we also know that if you have, greater than reasonable continuous intake of alcohol, your chances of having atrial fibrillation are greater, and you're also underhydrated over the long run. Weight is a big contributor in a number of ways, right? So really, all of our clinics should target weight before we target anything else.
Hmm.
Um, being overweight puts you at risk for diabetes, high blood pressure, high cholesterol, heart failure,
Well,
stroke,
you're messing
atrial
around with completely
fibrillation.
the metabolism
You're
of that.
messing around
Yeah.
with everything.
Yeah.
And specifically, if I'm going to put my blinders on, yes, there's lots of evidence, both animal evidence and human evidence, that gaining weight increases your risk of atrial fibrillation, losing weight reduces your risk of atrial fibrillation. That correlation is clearly there. And in fact, I'm sure you're running programs. We've run program called Ideal Protein years ago, which was a
Yeah.
keto diet, and we've seen significant number of people um, whose requirements for medications for a number of these conditions have come down. Their
Yeah.
arrhythmia management, had improved. This day and age, a lot of it is about using the GLP-1 medications,
Of course. It's all
like
over the conference
Ozempic,
this year. I don't think I've ever seen it advertised so much before. This was
right?
the first, mind you, the study just came out in 2024 early, right?
So
Yeah.
interestingly, we participate quite heavily in research studies, and we participated in STEP HF and STEP diabetes,
Mhm.
which were studies
Yeah.
with Ozempic. And in STEP HF, these were patients with heart failure, who were overweight,
Yeah.
and as they lost weight, the heart failure, well,
Was
got
better.
better.
Yeah.
And atrial fibrillation was kind of not even a secondary endpoint, it's like a tertiary endpoint, and they didn't really look at it very carefully. So they didn't really focus on AFib.
Yeah.
But even without focusing on AFib, they found that however which way they defined atrial fibrillation events, they went down by 50% in the
Yeah.
patients who lost weight. So clearly makes a big difference. And another way that it makes a difference is through sleep apnea. If you're overweight, you're going to be more likely to have sleep apnea. If you have sleep apnea, you have these surges of adrenaline, noradrenaline. When you stop breathing, your body tries to wake you up. You're not getting enough rest. You're not getting enough proper deep sleep.
Hmm.
You're getting the surges of hormones. Your blood pressure goes through the roof. You're at risk for stroke from the blood pressure changes.
Yeah.
You're at risk for stroke from atrial fibrillation that you can get. So sleep apnea, clearly correlation with atrial fibrillation,
Yeah.
independent potentially of the weight.
Well, that goes on that side of things. And I always talk about hormonal imbalances there, right? Especially with women with perimenopause or menopausal symptoms, or even for males, like if there's any hormonal imbalances, stress, like
Right.
those things can affect that rhythm of the heart,
Right.
right? So that's not sleeping well
Right.
does that. So
And anecdotally and empirically, lots of patients come to me. I've had a number of patients who have had palpitations or arrhythmia around their periods, for instance, right?
yeah,
But it's a bit out of my kind of comfort zone as far as,
of course, yeah,
I don't know from the research perspective if we really know what that correlation is and can fix it. But there clearly is a correlation. Some people are more likely to have arrhythmia related to, hormonal changes, hormonal
of course,
imbalances.
yeah.
And then from the point of view of, what else can you do? So, sleep, weight, alcohol, caffeine, hydration. Number of patients do better with magnesium. We find that a lot of patients are walking around with relatively kind of low normal magnesium levels.
And it's responsible for 300 some different biochemical pathways in our body.
It's
It's
important
amazing.
and
Yeah,
it's natural,
yeah, yeah,
and it's over the counter.
yeah,
So if you have kidney problems, you should not be taking too much magnesium because you can accumulate it and can cause problems. If your kidneys are working well, the likelihood of accumulating magnesium is relatively low. You're gonna, your body's gonna get rid of the extra
of course.
magnesium anyway. And if you're taking too much magnesium, most people will have diarrhea.
Yeah, of course.
So a lot of my atrial fibrillation patients, we recommend that they take somewhere between 200 and 500 milligrams of, either magnesium oxide or preferably magnesium bisglycinate, which is supposed to have better absorption.
Mhm.
And we're aiming for magnesium levels around kind of 0.9 to 1.0 in these patients.
Yeah.
Now, is the evidence strong? No, the evidence is pretty weak. But there is some acute evidence in patients who are having hospital, atrial fibrillation in the hospital, that giving those patients magnesium can help control their AFib.
Yeah.
And there is soft evidence, on an outpatient basis, but that's kind of part of what we generally talk to patients about.
Yeah. So we have the lifestyle, we have beta blockers if their rhythm's too high, we have antiarrhythmic drugs like the flecainide or the amiodarone, and those do work, like some of them can work, but it's almost like what is going to work, right? It's almost like a trial and error to see what works with medications.
Since you've mentioned some specific medications, when we talked about rate control and slowing your heart rate down, we talk about digoxin, beta blockers, and calcium channel blockers, generally speaking.
Yeah.
And all of these medications, work with some effect to slow your heart rate down. But, calcium channel blockers may also give you low blood pressure. Beta blockers might give you erectile dysfunction and just make you feel tired. And digoxin doesn't work very well when you're active. It only works, at rest. You can very easily become ditch toxic, etc. With antiarrhythmic drugs, you have your sotalol, which is basically a beta blocker, and what we call a class 3 antiarrhythmic. It has a risk of extending your QT interval, which is potentially life-threatening. So if you're older, your kidney function is not that great, you should not be on sotalol. Flecainide and propafenone work very well, but they have this tendency where they can make your atrial fibrillation into a very slow-ish atrial flutter at 150 to 100 beats per minute. But then your heart paradoxically can conduct potentially at 150 to 200 beats per minute, and that becomes a life-threatening rhythm. And so flecainide we don't use by itself. If you have to use flecainide, we typically give it with a beta blocker or calcium channel blocker. So now you're in two medicines.
Yeah.
And again, it might work about 30% of the time and potentially make you feel tired. Dronedarone was on the market for a little while. I think it still is. It's kind of a weaker version of amiodarone, actually weaker than flecainide or sotalol, without some of the side effects, but not great for heart failure patients. And amiodarone works. Amiodarone works about 50-60% of the time, but it accumulates in your body. And it
I
can.
see a question just came out about amiodarone there. So maybe if I can
Sure.
really ask this, is because this person's been on amiodarone for 6 months, and he was an AFib about 2 to 3 times a week for about 30 hours. And he's not been an AFib now for 2 months. So when you say that, I know exactly what's going on. And so, how important is it to get an ablation ASAP and get off of amiodarone? That would be a very important thing.
It's a nice segue.
Yeah.
So, amiodarone works well, but it accumulates in your tissues.
Yeah.
And if you take it long enough, it will always accumulate in the eyes. You have to get eye checks. It may eventually interfere with your vision, but 100% of the patients do have accumulation in their eyes. 100% of the patients get it in the skin. And so if you get exposed to the sun, you get sunburn. And if you get repeated sunburns on amiodarone, your skin turns blue, which most people don't generally like.
Yeah.
And then pretty well 100% of the time, if you're on it long enough, it will interfere with your thyroid. You'll become either hypothyroid or hyperthyroid. Now, life-threatening issues with amiodarone, very few people get into problems with their liver or their lungs. Those are rare. Even more rare is an effect where it may affect your central nervous system, and you can get almost kind of tremors, Parkinsonian symptoms, etc. That's very rare.
Anyway, thank you very much for your time today. And
Absolutely.
yeah, that was
Great.
fun. Yeah.
Thanks so much,
Yeah.
Diamond. Pleasure chatting with you.
Excellent.
And look forward to working with you.
Absolutely. Thanks so much.